the session in any minute. Let me just check. My dear students, good morning. I think we have now time is nearly 11 o'clock. Let's today we are now in module 14, wherein we are going to discuss another important topic in acute abdomen, that is small bowel obstruction. And therein we will have at least two. One is a short notes and the other one is a essay, that is short notes on strangulated small bowel obstruction, and probably an important essay or important point for discussion in ileocecal tuberculosis. So these are the things we are going to see. So let me just and this is just a repeat of what I used to have in my template slide. That is, every time when you discuss with me, you need to use the same template we used on the module number 1. That is, you approach every patient with his prime symptom. Here, it's going to be central colicky abdominal pain. If anybody coming with the central colicky abdominal pain, it is some sort of obstruction to the bowel unless proved otherwise. In that situation, what are the common causes? So it is then out of them, how to approach. That is, what are the symptoms, signs, investigation. In the investigations, what are the simple blood investigation, radiological imaging. Then what about management, conservative management and surgical management? And what are the outcome and what are the complications and what we learned as a key messages from that day. So this is the template. We have been using it all along, and it should become a habit for every one of you to use that. Don't, because each chapter in your book is written by a different person, so they have a different style of presentation. If you go by that, it is very, very difficult for you to not only to understand and also to write in the exam. So you just understand everything in the template based approach. Then you, along with me there and then telling some important key words or mnemonics, you keep a note. So you think like a surgeon, because the surgeon in front of you, if he is asking a question either in the Viva and clinical, if you say the same way I'm just telling you, then it will be easy to pass the exam, because our aim after all is to get through this exam with the flying colors. So with that aim, let us move on today on an approach to small bowel. And already the last 2 classes, as you know, we have discussed the 5 common presentations or 5 different baskets, I would say, of acute abdomen. We have discussed acute pancreatitis as a classical example for shock or a catastrophe. That is, patient presenting with hypovolemic shock with tachycardia and hypotension. That is the one we have discussed once. That is about 3-4 modules before. The second case we have discussed is itis. Any people or any person presenting with a localized tenderness and guarding because of the inflammation of the offending organ. Maybe appendix like appendicitis, also acute cholecystitis due to gallstone. Both we have discussed and we know them all in details. So go and revise. So 1 and 3 we have finished. Now we are coming to the most important thing, that is number 4, that is block, either in the small bowel or large bowel, maybe because of mechanical obstruction or a functional obstruction. So there are two sites anatomically, and there are two types of obstruction, either a dynamic and a dynamic, or mechanical and a functional or neurogenic. So these are the two. And of course, we are going to visit next week, hopefully, on whole, that is generalized peritonitis. And then the following week, I'll be probably discussing something about acute traumatic abdomen, that is a blunt injury abdomen and chest. Then you will be very confident managing all acute situations in the abdominal conditions. After that, I'll take you to module number 17, 18 on portal hypertension and also various places where we do a splenectomy, causes for splenomegaly. Because only after that, you'll know all the common conditions in GIT. Then we'll come to a next important clinical examination long case, that is approach to abdominal lump, be it a right leg fossa mass, hepatomegaly, splenomegaly, renal mass, or pelvic mass, or ascites patient, all abdominal lumps, if they are brought as a long case, how to approach, unless you understand all these pathologies, very difficult to examine. So we are how to spend 3 or 4 modules. By module number 19 or 20, we'll be completing all common abdominal conditions. Then the last 10 modules will see other clinically important relevant topics. And the 2 modules before your exam, that is module number 28, 29, 30, will be like the common clinical signs, common radiological examination, common surgical instruments. So like that, I'll take you. So my job is to make you all and 100% pass in this final year examination. And we have nearly halfway mark. So good luck. Let's move on. So I said this case, even today, we are going to see a case where we are going to have this 5-point or 5-step approach. Imagine a patient is walking or brought in a wheelchair with a severe central abdominal pain. You just listen to him carefully, get a good history. Then ask him to lie down, inspect, palpate, percuss, and auscultate, of course. And you come to a clinical diagnosis. Then investigate in this particular patient with the suspected intestinal obstruction, the various hematological, biochemical, and radiological investigations, out of which one is very, very important, that is X-ray abdomen, erect and supine. That is the investigation for this particular chapter. Okay. Then all these people, especially intestinal obstruction, they'll be vomiting a lot. So you have to rehydrate the dehydrated patient. So you have to optimize this patient. Then you plan for treatment, either surgery or medical treatment. So this is the way we are going to approach these patients. Okay, let's move on. Just understand there are 4 cardinal symptoms of intestinal obstruction. One, of course, is like this patient, a periumbilical colicky abdominal pain. In other words, the pain is coming and going, or waxing and waning, or coming in waves. In other words, the patient will go crescendo type of pain and then gradually coming down. So he is feeling okay, I'm getting better. But again, it comes with a vengeance again. So it's just like this. The pain will be coming and going. A typical colicky central abdominal pain. So the patient will be a restless patient. He'll be rolling. In other words, he'll be jumping from one cart to the next cart if you have to make, because he is restless. And he'll be keeping on putting his hand like that. And even if somebody is applying something like an oil over his abdomen, he feels psychologically better because some pressure, it gives him some comfort. That's all. So colicky abdominal pain is a classical feature of any pain because of the obstruction like here. For example, what happens in the bowel, you imagine the distal small bowel in the ileum, if there is an obstruction because of tuberculosis, for example, the proximal bowel gets distended. All the contents in this bowel trying to go through this narrowest part. So because of that, the powerful peristalsis causes the distension colicky pain. That is what the mid-gut pain, that is a peri-umbilical pain. Next, but it is not going to go through this obstruction. So whatever is the content here, it comes out. Initially, it will be only the content of the stomach. So it will be non-bilious. Then this biliary content, that is duodenum and proximal jejunum, then it is bilious in nature. And if the content from the distal small bowel, if it comes, then it becomes more brownish, or I call feculent. Because of the bacterial proliferation in the distal small bowel, it becomes a odor is there. So if you see a brownish, foul smelling, feculent looking vomitus, it is actually a delayed presentation of intestinal obstruction, and the patient is usually very dehydrated, because by the time the whole intestinal content has come out, like 2 liters, 3 liters, so they'll be terribly dehydrated. So abdominal pain, vomiting, initially non-bilious, bilious, brownish or feculent. That is the order. Okay. Then abdomen becoming distended, like 3 months pregnancy, 4 months, 6 months, like that, slowly getting bigger and bigger, and very tense also at times. Okay. And because obviously it is so obstructed, even the gas from the proximal bowel cannot go through this. So he is not able to pass even the flatus, very important symptom. So not passed motion for a few days, not passing flatus for the last 24 hours, a cardinal symptom of complete intestinal obstruction. So pain, vomiting, distension, constipation. All the 4 have to be present to say it is a classical intestinal obstruction. Good history will clinch the diagnosis. There are a humpty number of causes for this block or a small bowel obstruction. Let us concentrate today on what are the small bowel obstruction, because that itself is a big chapter. Then next week we'll go for a large bowel obstruction. And I indicated in the colonic cancer itself, one of the common cause for large bowel obstruction is, of course, obstructing left-sided cancer like sigmoid carcinoma or rectosigmoid carcinoma. That is in elderly people. But other causes for large bowel obstruction also, will come to that next week. This week, let us concentrate on small bowel obstruction. And here are the 4 common causes. Okay. See, for example, first let us understand some terminologies. In intestinal obstruction, when you write, first you put a nice diagram of the whole small bowel and large bowel, then you write. The obstruction could be 1, dynamic, adynamic. Dynamic is otherwise called mechanical. Adynamic is functional. Dynamic in the sense there is some definite organic pathology. You can have a look. And because of that, the patient will have a severe pain. Pain is a very significant feature of mechanical bowel obstruction, whereas adynamic, all other symptoms will be there. Pain is predominantly absent. So pain is absent in adynamic, otherwise called a paralytic ileus. Okay, all the P's, you remember P. Adynamic ileus is called a paralytic ileus. Number 1. Second point, pain will be less in this particular condition. And it is usually noticed in a post-operative patient. For example, if you've done a surgery today, any surgery for that matter, the next day and the following day, the bowel sounds will be absent, because you all handle the bowel during surgery. So because of that, the bowel goes for a strike. That is post-operative ileus. That is one of the common cause for paralytic or adynamic obstruction. The second thing is another P, potassium. If the potassium is low, there is hypokalemia, that again can give rise to this problem. The third important thing is, if you have a patient with a neurological problem like a paraplegia, like a spinal problem, they'll have ileus. And fourth, rarely, then you can have a condition called pseudo obstruction, another P, that is called Ogilvie syndrome. So pseudo obstruction, paraplegic patient, post-operative patients, or you have a patient with the potassium lack, that is hypokalemia, or few of the causes for adynamic obstruction. They are rare. What is more common is a dynamic. let's go on to the other classification. We usually classify the next important is a very important classification for a surgeon, classifying the obstruction as simple, strangulated, and rare a closed loop obstruction. What is simple? That is intestinal obstruction with no problem with the viability of the bowel. In other words, the bowel is viable. That is, it is retaining its blood supply. It is nice and pink colored bowel. Whereas if the bowel is not only getting obstructed like strangulated inguinal hernia, it loses its blood supply because of the constriction band is so tight. Then it becomes like what you see here, black colored bowel with a lack of peristalsis. Okay, then it is strangulated bowel obstruction. That is a surgical emergency. Tell some common conditions for surgical emergency. Somebody asks you, you tell perforated appendicitis, gangrenous gallbladder, perforated duodenal ulcer, strangulated small bowel obstruction, strangulated inguinal hernia, leaking abdominal aortic aneurysm. Why these are important? Because you are working against the time clock. If you delay the procedure, if you think that I'll go back and see this patient next day morning, patient may not be alive. So it is very, very important. So whatever you are going to do, operate or do, is a life-saving for the patient. So strangulation is a very, very important surgical emergency. We have to go for early diagnosis and treatment. That's why it is important. So strangulation means bowel with the loss of viability. Can you give some example for strangulated small bowel obstruction? Yes, sir. Whenever the bowel is obstructed because of the hernia, strangulated inguinal hernia, first classical example, or the bowel inside goes for torsion or a twist, like a strangulated intestinal small bowel valvulus. One of the classical condition is mid-gut valvulus called valvulus neonatorum. Very, very important surgical emergency in a newborn baby is called valvulus neonatorum. You go back and read that. Here, this whole small bowel, because of the narrow mesentery, it revolves around the superior mesenteric artery, goes and loses its blood supply. If you don't recognize this, the child succumb because the whole small bowel will go for gangrene. Okay. Next, of course, is a closed loop obstruction. What is you mean by a closed loop obstruction? Because till this time, if you see, let me go back this slide. Here, the obstruction is only one level obstruction. Simple obstruction is a one level obstruction like here. Whereas in a closed loop obstruction, it is a 2-point obstruction. What is 2-point obstruction? As you can see here, there are obstruction here. So both the proximal and the distal, both areas it is obstructed. So because of that, you here and here obstruction. So patient will have only one loop which is obstructed, will go for a distension. The bowel distal, bowel proximal, both may be near normal. So only this part is going for an obstruction. Because whatever distension is here, this distension is not transmitted even proximally. See? So that's a very unusual situation. But because it's like a constriction, somebody is strangulating you like a neck, the patient is having some classical features. What are the things? The obstruction is at 2 points, both proximally and distally. The pain is more severe, but the distension of the abdomen is less because only one loop, not the whole small bowel is distended, but it is a very serious condition because there is always this bowel, unless you are releasing this band, this is going to go for a strangulation. Risk of strangulation is there, and also there is a risk of perforation. What is the perforation? Another important site of closed loop. One loop is a band across a loop of small bowel. That is the one common cause. The next common cause for a closed loop obstruction is here. Imagine you have a tumor in the transverse colon. And imagine the ileocecal valve in your body is very competent. What is meant by competent? It is not incompetent, okay, like a varicose vein. So if it is competent, It will only allow the small bowel content to enter the large bowel content. It will not allow the large bowel content to go back this way. So it is one-way traffic. If it is one-way traffic, what will happen? If there is an obstruction here, there is nothing is moving from here. So all the contents from here, it causes distension of the ascending colon and cecum, and small bowel keeps supplying all the effluent. Everything accumulates. They have nowhere else to go, and it goes for what is called the cecum goes for a blowout. Cecal blowout, cecal perforation is the one of the dreaded complication because of this closed loop. Because is a okay. So these are the two things, that is the bands in the small bowel and also right colonic tumor. Okay. Next, let us come to the other types. That is, this is more important for you whenever you have a patient presenting with a tubular organ having an obstruction, be it bile duct, small bowel, ureter, large bowel. Take it from me, I told you several times already, or esophagus, intraluminal cause, within the wall, and outside the wall. So you need to have three different causes. This is a classical classification we have to adapt whenever we are trying to find out the etiological reason why this patient developed a small bowel obstruction. If anybody asks you, then you tell there are about 15 different causes. They can be grouped under this three broad category. The category number one is intraluminal. Especially in our country, one of the very common thing in, at least in children, is worms. Ascariasis lumbricoides or roundworms, hundreds of them, okay, like a worm ball, they can get obstructed. If you see one condition, you will never forget. It is not common in, at least in our state, Tamil Nadu, but quite common in other states in our country, causing an obstruction in a child. Okay. Or occasionally you can have an obstruction because of vegetable matter causing obstruction to the wall. Phytobazar. Or we have already read in the gallstone, one of the rare complications of the gallstone is gallstone ileus. Isn't it? Gallstone coming and stuck in the terminal ileum. So these are all intraluminal causes. And of course, in children, sometimes even a meconium, thick meconium, then get insippisated, dried up, and causes obstruction. These are some causes. And a foreign body. There are Humpty number of foreign body in the small bowel. One of the things we call is a stent. Sometimes you place a stent in the esophagus, it can travel, migrate, and cause obstruction. So there are various rare causes, but at your level, if you know worms, phytobazar, gallstone ileus, well and good. Coming to the wall. Within the wall, it could be a benign or malignant stricture. Malignancy of small bowel is rare. Take it from me. There are only rarely you can have carcinoid of small bowel, carcinoma, adenocarcinoma of the small bowel. They are very rare. You don't even see it. Only esophagus, stomach, then large bowel. Because the transit time in intestine, small bowel is so much. So there is nothing much happening as far as the cancer is concerned in the small bowel. That is a peculiar observation. Okay. Anyhow, coming back to the benign pathology, the two common inflammatory pathology common in small bowel, especially in the terminal ileocecal junction, is ileocecal tuberculosis and also Crohn's disease. Both can happen, causes stenosis and obstruction to the distal small bowel. Next, more common, the commonest cause for intestinal obstruction is extraluminal. Take it from me. So what are the causes for extraluminal? If you go, here is another slide. This is another Crohn's disease. We know Crohn's disease from our class. It can affect any part of the bowel, starting from oral cavity down to the anal cavity. But the common site is the terminal ileum, ascending colon, rarely some other parts of the colon, perianal region. Same thing holds. Here is a stricture of the small bowel because of the Crohn's disease. Extraluminal, I told you, is a Humpty number of causes are there. And one of the common cause, or the two common causes, are A and B, adhesion and bands. Whenever patient undergoes surgery, like you have a hysterectomy in a lady, appendicectomy and you're a child, then you're bound to develop bowel stuck to each other, that is adhesions. Okay, so the bowel gets tethered, what we call a kinking of the bowel. Wherever there is a stuck, it will kink, like tethering of the bowel here. Okay, or it can go right through the loop of bowel, like here, band. Band is going right across a loop of bowel, so it can cause. So here is another band. So A and B, adhesions and bands, are the penalty we pay for previous surgery. That's why all patients with a small bowel obstruction, one of the important things you have to ask patient is, have you undergone any surgery in the past? If so, what surgery? And after surgery, the post-operative period, did you have any infection of the wound? Because if there is infection, scarring, and at that time there will be more scarring inside also. That is a important history you have to elicit. Okay. So what is adhesion? Kink bowel, band, constricted bowel. So these are all key layman terminology. Okay, you have to tell in the same way, because if you tell you have adhesions, the patient may not know. You can tell it is like a bending, hooks or bends. Like when you go into Ooty, all the roads are like kinks in the roads. Similarly, your bowel also getting kinked where it is stuck in the site of the hysterectomy or site of appendicectomy. One of the bowel loop go and got stuck there. That's why you are having a signs of acute or subacute obstruction. Other common conditions you already know as undergraduate by this time. Various types of hernia prone for obstruction, like inguinal hernia, both sides, femoral hernia, especially elderly female, umbilical hernia, where there is a knuckle of bowel can go. That is called a rectus hernia. That's right. Okay. So all these various hernias, you know, out of them, the most important thing is femoral hernia, never forget. Next is umbilical hernia. These are the two common causes for strangulated small bowel obstruction. Okay. And internal hernia, which are hernia inside your body, you will not be able to see it outside. That is something like a hiatus hernia or a diaphragmatic hernia. So these are all the various hernias that can go for a strangulation. Other causes for strangulation and other causes for extraluminal causes are a twist in the bowel or telescoping bowel. The bowel going one into the other, like the proximal bowel going to the distal bowel, like a telescoping like this. Okay, this is a classical intersusception, because the bowel here, okay, it thinks there is some food inside. So it was trying to push. In that process, it is pushing itself into the lumen. So intersusceptum, it is becoming a advancing port. So this is very common in children, especially if the bowel wall is having a hypertrophied Peyer's patches after respiratory infection. So enlarged Peyer's patches in the terminal ileum causes the terminal ileum prolapsing into the right colon. Okay, ileocolic intersusception, telescoping of the bowel. Next thing is twisting of the bowel. Small bowel can rotate or torsion of the bowel. Torsion testis, you know, whenever there is a word torsion, it's a twist. When you have a twist of a long, narrow mesentery, then the blood supply also is obstructed. So you have an ischemic necrosis of that part. The bowel goes for a closed obstruction, goes for necrosis, strangulation. Okay, very easy to comprehend. So this is what I call a medical terminology. This is what you need to explain to the patient. Okay, what is intersusception? If the examiner asks you, if you don't know how to define, you tell it is nothing but telescoping of bowel, sir. That is a proximal bowel telescoping to the distal bowel. Okay, it is always prograde, never antigrade. Okay, very, very important. Okay, you don't say coloileal intersusception. It is a ileocolic intersusception. So it could be jejunal-ileal, ileocolic, colocolic, like that. It will come, okay, more and more distally. And a twisted bowel, valvulus of small bowel, valvulus of cecum, valvulus of transverse colon, and valvulus of sigmoid valvulus, commonest one. Okay, all different valvulus we see. Hernias, different sites of hernia you have seen. Bands and adhesions, the by far the commonest cause is A and B. Like, for example, if anybody asks you what are the common cause for jaundice, you say A and B. What is A and B? Hepatitis A and hepatitis B. Common cause for cirrhosis, A and B. What is A and B? Alcohol and hepatitis B and C also, cirrhosis because of hepatitis C virus. Okay, D also sometimes you can have diabetes and also some idiopathic causes. So you should have some way of remembering because in the exam, answers should be coming just like that. Imagine now you are seeing a patient lying right in front of you with a intestinal obstruction. So obviously he has been vomiting the whole night. So he'll be hypovolemic shock, dehydrated. People will say, what are the signs of dehydration? You ask a patient to put the tongue out, dry tongue. Look at the eyes, it will be sunken, indrawn eyes. And see the skin ridges. If you see, usually you and me have elasticity, but their skin will be skin of a 90-year-old lady with a loss of elasticity. The skin, if you lift it, it will remain like a ridge, skin ridge, because of lack of elasticity, because of lack of water. So these are the signs of dehydration. So dehydrated patient needs rehydration. The best fluid for rehydration is normal saline. Okay, 0 to 9% saline, nothing else. Anemia is a common finding in these people, look for it. Next is a locally, you in exam always have the habit of writing your findings, general and local. In local, don't just write all the findings, put inspection, palpation, percussion, auscultation, then you put a diagram like a hexagonal and put like a one line, like a midline scar. So I look for any distension, scar, and in the hernia site, you put a small hernia, and that I look for a hernia and look for the VIP. It is not a very important person. It is a visible intestinal peristalsis, like a visible gastric peristalsis we see in the gastric outlet obstruction, GOO. So GOO, BOO, all these things, you know, GOO is gastric outlet obstruction, BOO is bladder outlet obstruction, BIP, visible intestinal peristalsis, all these mnemonics or whatever that better you try to expand. Don't tell VIP, I look for VIP. Then are you a VIP? Exam will ask you. So don't go and get trapped. You always try to expand. I'll go for a cardiovascular examination. Don't say CVS RS exam. Don't say that until you pass the examination. Be a obedient, sincere student using all these complete terminologies. Don't go in a hurry because everywhere people will try to find fault at you. So try to be as perfect, near perfect as possible. Okay. Coming to the palpation, when you palpate with your warm hand, just do like that and feel it. And if usually the abdomen is distended, soft in a simple small bowel obstruction, whereas if there is a strangulated small bowel where there is a dead gut or non-viable bowel is there, the two classical signs are presence of localized tenderness, patient says, that hurts, and also that area there will be some rigidity or a guarding. Okay, you will sometimes even feel a mass-like structure. So rigidity, guarding, or what we call a rebound tenderness, Blumberg sign, we called last week, Blumberg sign or a release sign, where you feel as you are conversing with the patient, when the patient is least expecting, suddenly you take the hand out. When you take the hand, look at the patient's face, don't ask him, the patient's face will go with the winch. He'll say that face will say that patient didn't enjoy you taking that hand suddenly all of a sudden. So that is a telltale. It is more of a signal. Patient will give you a signal that there is a rebound, a release sign. So it is nothing. Patient is declaring, he'll, sir, that one is hurting. Don't ask, does it hurt? Does it hurt? Nothing speaking. You just keep talking to the patient. As you talk to the patient, hi, how are you? Like that, suddenly you release the hand and you release, look at the patient face. He'll show all the findings suggestive of rebound tenderness. Okay. Percuss. When you percuss, there will be, because it's a gaseous distension very many times, there will be tympanic or hyperresonant note and auscultate and bowel sounds everywhere. It is a noisy abdomen we call. Whereas in just opposite to peritonitis. In peritonitis, which we are going to see next week, there is a hole in the bowel, the absolute silence, like a prayer hall or a meditation hall, the stethoscope you put absolute silence. Whereas here, noisy. It is like a nursery. So where there are children shouting each other, making noise, nurseries, a noisy abdomen, okay, and hyperperistalsis because of the peristalsis. Okay, so that's a classical finding of intestinal obstruction. And here are the various investigations I told you. You look for hematological. If patient is having a strangulated small bowel obstruction, they'll have full blood count. Okay, let me just. Sorry. Okay. I just want these annotations to go. Let me just see how to do it. Right, let's carry on. Let's move on to the investigation. So this investigation, when we do hematological, biochemical, and radiological, okay, and hematological, when you go full blood count, packed cell volume, that is, I told you already, these people will very often will have neutrophilic leukocytosis, especially when they have a strangulated small bowel. Very often they can have anemia also. Biochemical weight is important because they are hypovolemic shock. Very often they may have raised urea and raised amylase at times. Pseudo hyperamylasemia they can have. Okay. Electrolytes, sometimes they can have electrolytes also abnormal. Okay. Especially hypokalemia can give rise to also adynamic small bowel obstruction. Okay. Then coming to the radiological investigation, okay, you have to go for a X-ray chest, X-ray abdomen erect and supine, ultrasound abdomen. I request candidates refrain from using the annotation because it is disturbing me here. I think somebody is either knowingly or unknowingly doing. Please don't do any harm. Then X-ray abdomen erect and supine, ultrasound abdomen. Yes, Rajaram. I'm not able to see it now. I'm just going to carry on. I'll do the discussion point. I will do it. Okay. So let's continue. X-ray abdomen erect and supine, CT scan abdomen. These are the two prime investigations we have to go through. Okay. All other things are there. That is mainly for our postgraduates. Let's go on for X-ray abdomen. How to see? See, whenever you see an X-ray, you need to see the soft tissues. What are the things you will appreciate? You'll be able to see the right upper part of the liver, then left side sometimes the white color, the spleen, the right kidney slightly at a lower level compared to the left kidney, and the psoas margin you will be able to appreciate. Sometimes you'll see some gas here, that is usually the gas in the cecum ascending colon. Sometimes you see some gas in the left iliac fossa, that is usually the gas in the descending and sigmoid colon. Rarely you'll see a gas in the rectum also. So this is, and of course you have a vertebra and sacrum, sacroiliac joint and the ilium, hip joint, all these things. You don't see the diaphragm in an X-ray supine, whereas in an X-ray erect and X-ray chest, you will be able to see the diaphragm. Okay, this is an overall. But when you are going to see in a supine abdomen in an intestinal obstruction, what you have to understand, you look for is CVS. You look for CVS. What is CVS? That is, you see, first of all, these dilated loops of bowel in the central part, because small bowel occupying our central part of our abdomen, whereas large bowel, ascending colon, transverse colon, descending colon, all in the periphery. So whenever the dilated, dark, gas-filled loops of bowel are predominantly occupying the central part of the bowel, that is small bowel. Take it from me. So C, central. Second, if you carefully see here, all this small white color, that is, you can see white, the mucosal folds inside are becoming edematous. They stretch from anti-mesenteric to the mesenteric border like this. You'll be able to appreciate here also. So you can appreciate here also where I'm dragging the arrows. Okay, they are called valvulae conniventes. Valvulae conniventes are nothing but complete mucosal folds normally seen in the proximal small bowel like jejuna. They are telltale evidence radiologically the plain film that what you are seeing there is actually jejuna, because you know the mesentery stretches from where DJ flexor to ileocecal junction, that is from there to here. Okay, and that one jejunum is here, ileum is here. Okay, so whatever loops of bowel where my arrow is showing, the proximal left upper quadrant, they are all usually jejunum, whereas the right lower quadrant here, usually it is the ileum. Okay, not always, majority of the time. So here all the bowel in the proximal left upper quadrant, they'll have the typical valvulae conniventes, and the bowels are arranged like layer by layer like this. This is the typical what I call a step ladder pattern. One step, second step, third step, step ladder pattern. So this is a CBS. So when anybody asks you what are the classical 3 radiological appearance in supine abdominal small bowel obstruction, dilated bowel in central location, presence of mucosal folds, otherwise called valvulae conniventes, step ladder pattern. Good. Next, what about erect? Why that? Because in erect, everything settles down. Fluids go down, gas lifts up. So all gas-filled part of the bowel will be here. All the fluid, you have to imagine every loop is like this. So all the fluid is stagnating as the patient is sitting or standing. So here, see, for example, 1, 2, 3, 4, 5 loop. So 5 fluid levels. What about here? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. At least 10 fluid level minimum you can count. And whatever you see white color, they're all fluid filled. You don't see the fluid filled because they merge with the rest of the whiteness. So this is the what you see. The multiple fluid levels you'll be able to see. Normal fluid level, you and me, is only 2 levels. One, stomach, another is the ileocecal junction. Okay, usually nothing more. So any level more than 2 is abnormal. 3, 4, 5, jejunal obstruction. 6, 7, 8, 9, 10. That is ileal obstruction. In other words, more the level, lower the level of obstruction. Okay, or more distal the level of obstruction. So very simple, very important statement I've just made. Okay. Coming to the treatment, what is the treatment for a small bowel obstruction? We don't rush to the treatment of surgery in all patients. Provided the patient's BP pulse stable, provided there is no tenderness or a guarding, which are the 2 signs of strangulation, it is not a surgical emergency. We have at least 24 hours to wait and watch. That is what important in small bowel. So small bowel obstruction, flow chart, you write strangulated small bowel, simple small bowel. Simple small bowel, 24 hours conservative treatment. Strangulated small bowel, investigate, operate immediately, same night. Okay, this is the different flow chart. In simple obstruction, which is 80% of the conditions, you see only simple. Majority of the conditions are simple. So we spend some time. What do? You do a simple treatment that is called a drip and suck. What is meant by drip and suck? Patient is dehydrated. So give fluids, drip IV fluids by putting a Venflon, infuse them with a normal saline normally, and later depending upon the electrolyte imbalance, you give appropriate crystalloids. Crystalloids are fluids like a dextrosaline, normal saline, ringer lactate. These are the 3 types of crystalloids. Colloids are something like a plasma or albumin. Okay, these are all the things you can see. Sometimes you can also have hemoxal. Hemoxal is a starch. So these are all the things which stays in the intravascular compartment longer. whereas crystalloids tend to go into the extravascular compartment. Okay, so you need to give larger volume of crystalloids, calculated volume or a limited volume of the colloids. That if you know, that is well and good at the undergraduate level. Coming to the outcome, what is good? A successful consider. For example, a patient comes at night, there is no guarding and tenderness, no strangulation. You put the patient nasogastric tube, aspirate, there is Rayleigh tube aspiration. Give some fluids, wait for 24 hours. If possible, you give him also phosphate enema. So patient passing flatus feces, that means the obstruction settled by conservative treatment. Waiting game like phytobazar or some obstruction relieves itself. It can happen. But if the patient is persisting symptoms or patient develops some severe symptoms, then you need to do what we call a laparotomy. That is open and have a look by a midline. So once you have done preoperatively, optimize the patient by giving adequate IV fluids. We take the patient always, the laparotomy for small bowel obstruction is long midline incision from zibisternum to suprapubic region, long midline incision, you write. Or even you put a hexagonal umbilicus, long incision like that you put. Okay, thorough laparotomy. What do you mean by? We start from all the bowel from esophagus, stomach, everywhere you have a look. Okay, look at and find out the etiology, pathology. Where is the pathology and what is the pathology? Depending upon that, if it is adhesion, you do the treatment for adhesions. Hernia, you reduce the hernia. If it is, for example, dead bowel, you may have to remove the dead bowel. So what we do here, for example, if bowel is found to be stuck in the abdominal wall like this, so you release this bowel. By scissor, we'll just cut this, and the kicked bowel is made a straight bowel. Then, for example, if you see a dead bowel, see this is a nice pink bowel, peristaltic bowel, dead bowel with a lack of peristalsis. Then you remove all the dead bowel. Okay, dead bowel, so very easy to see. There is no need for any test. It is all surgeon has the capacity to make a diagnosis. Clinical, in other words, inspection. Looking at the bowel, bowel is looking black, lack of peristalsis, lack of bleeding in the mesentery. You resect that bowel. You will be 100% right. Okay, dead bowel resect. And suppose if there is a hernia and there is through a small hernial defect, you reduce the hernia if possible. If the bowel is dead, you remove it like this. If not dead, you just repair this defect by putting a mesh, okay, a mesh like that. So these are all the remedial measures we do, okay. And what about the strangulated small bowel? I told you this can be a short notes for you. So you have to tell strangulated small bowel can happen in 5 to 10% of the cases with small bowel obstruction. Next, it is not always possible to diagnose before surgery. Sometimes it will be a surprise finding during surgery. But we need to have always suspect high index of suspicion should be there. When I will be suspecting a strangulated bowel, if the following symptoms, signs, investigation findings, if they are present, then I will suspect. Let us see. Symptom. What is the pain in intestinal obstruction? I told you already. It is a colicky abdominal pain. What about here? The colicky pain, if it start becoming a more constant or a continuous pain, suspect dead bowel. Second, normally when a patient with intestinal obstruction, when you put a Rayleigh tube, empty the bowel, in other words, decompress the bowel, patient pain will go away. As here in strangulated bowel, Rayleigh tube aspiration has no effect on the intensity of the pain. So that is another indirect evidence. You have to write patient pain continuously present. I have given 2 doses of pethidine, fortune, no relief. Rayleigh tube inserted, no relief. I suspect strangulation. Like that you have to write. Next is signs. What signs? If the patient start developing fever, signs of inflammation, tachycardia, Blumberg sign, bowel sounds which were like a noisy abdomen, becoming a silent abdomen. These are all the indirect signs of strangulation. What about investigations? White cell count, if it is raising, especially white cell count more than 20,000, take it from me, invariably means it is a dead bowel. Okay, it's the indirect evidence of very high white cell count. Usually from up to 10,000 is normal, white cell count. 10,000 to 20,000, you see all sites of acute abdomen like appendicitis, cholecystitis. But beyond 20, 25,000, only one condition gives rise to this, something like a leukemioid reaction, that is, you strangulated or a dead bowel or a superior mesenteric vein artery thrombosis. Okay. The second thing is lactate in the blood will be very high. Patient will have acidosis. pH will be low. So that is so blood gas analysis is very, very important, and it will indirectly tell this patient is acidosis. Two common cause of acidosis: diabetic acidosis, lactic acidosis. These two has to be differentiated. Here you will have a lactic acidosis. Okay. So coming to the shortcuts to diagnosis. If you see a patient with a small bowel obstruction and on inspection you find scar, then you imagine the etiology is going to be a scar outside, means he is also having a scarred intestine. Adhesions and bands should be your diagnosis. Very simple. Whereas if you have an intestinal obstruction in a patient who never had an operation, like a virgin abdomen, in that condition, it could be anything. Like it could be a small hernia. So look at the 10th compartment, look at the groin, or it could be a case of inflammatory bowel disease, or even elderly people could be a cancer, or intersection stone ileus. All these things can happen in a patient who had never had surgery. But if the patient had a history of surgery, any surgery for that matter like this, you have to tell A and B as your first and second diagnosis. Only then these can happen in the same patient. Okay. This is not too important for you, but it is worthwhile having an idea, especially if it is a prize exam for you as undergraduate. They'll ask you, can you guess the site of obstruction in small bowel? Well, because small bowel is so long, whether it is somewhere in the jejunum, small bowel proximally, or small bowel in the distally, like ileocecal junction. Where is the obstruction? Can you guess? If you take into account these four categories, like pain intensity, quantity of the quantum of vomitus, distension of the abdomen, number of fluid levels in the X-ray, you can give a rough. This one you already know, because more the level of fluid levels, distal the obstruction. I told you already. Second thing also you know, if it is a distal obstruction, the whole small bowel is dilated, so it's going to be gross distension of the abdomen. Whereas if it is jejunum is obstructed, nothing much to distend, only the stomach will distend. So the obstruction distension is going to be very minimal in the proximal. And also the pain is also relatively less in the proximal, more in distal. So you have a way to make a diagnosis, but that is academic, because once you do a CT or once you operate, you find the site and you find the etiology straight away. But if you don't treat these people early enough, people can die. In other words, small bowel obstruction, what is a simple one, can become a serious lethal problem for the patient, because the bowel can go for strangulation, perforation, then hypovolemic shock, sepsis, multi-organ failure, of course, the renal failure, coagulation failure, patient will go for a downward spiral and death. So that's why this has to be understood and treated like a, you see the myocardial infarction, you give that much of importance, same important, because it is eminently treatable condition. That's why you need to, okay. So let's go for the discussion now. Rajaram, are you still there? Let me, don't know where I can. I stop sharing the, sorry. I stop sharing the screen. Let me see whether I can, participants. Unmute themselves. Can you unmute now? Ask all to unmute. You can come now. Devika, Jakanniti, Karshini, any feedback? Ram Prakash, yes. Yes, Ram Prakash, would you like to ask anything? You have unmuted. You can ask me now, or you have gone. Anybody wants to ask? Because we have about another 30 minutes. I'm sure we can finish well in time. I leave you for 2 minutes. Yes, anybody wants to ask? No questions? Yes? I want at least one question before proceed further. Ramya N. Introduce yourself. Where are you from? Did you understand today's topic so far? Would you like to ask any questions in the last 45-50 minutes? Yes, Ramya, go on.
Sir, I'm from Trichy.
Where?
Sir.
Please be a little bit louder and clear because I couldn't hear you properly. I don't know whether the problem is on your end, my end. Yeah, go on, Ramya. Yeah, go on. Yes, can you hear me? Yes, I want to make sure I am here, heard by all of you because I should not be. Ram Prakash, can you hear my voice loud and clear? Then I can proceed. Yeah, you can hear me.
Yes, sir.
Did you find this so far? It is easy to understand, comprehend, or any areas you're not able to understand? Otherwise, you will quickly go to the next half an hour. Any clarification, or you are able to understand the concepts, the causes for small bowel obstruction?
Yes, sir.
Treatment for small bowel obstructions, you are able to follow without much trouble?
Yes, sir.
Okay, good. Thank you. So let's move on then. Sharing the screen. Are you able to see my pictures? Ram Prakash?
Yes, sir.
Please.
Yes,
Okay,
sir.
fine. Okay, let's move on because I need to keep an eye because my colleague, I don't know whether he's still there online. Let us move on to quickly to the abdominal tuberculosis without wasting much of the time because this could be an essay by itself. Abdominal tuberculosis, like pulmonary tuberculosis for a pulmonologist or medicine, is a very, very important chapter. I told you, if you know acute appendicitis, you know everything about acute abdomen. Like that, if you know abdominal tuberculosis or TB abdomen, and that you have understood everything about a chronic abdominal pain. So this is what I would say. Okay, so it is as simple as that. And why and in what extent is this problem? If you see, 10% of the extrapulmonary tuberculosis is confined to the abdomen because you can have pulmonary tuberculosis. Next is cervical nodes, cervical lymphadenopathy because of tuberculosis is common. Or you can have tuberculosis involving like a meningitis, or you can have other organs also can be like a bony tuberculosis. Like that, abdominal tuberculosis by entity can happen. It is very, very common in immunocompromised individual, like a HIV patients, diabetic patients, cirrhotic patients. All these people you need to know. And some people can have a combination of abdominal tuberculosis along with the active pulmonary tuberculosis. So these are all the background knowledge you should know. Why you get abdominal tuberculosis? Because I'm not going to tell like an essay. I'm going to tell you something just minimum to understand, and from that you create your own little short note essay. Why we get an abdominal tuberculosis? It is mainly the organism, somehow it enters the either GIT, how maybe because you have the lung tuberculosis initially, and from there the sputum swallowed with an active bacilli, that's caused multiplying and causing, that is swallowing of infected sputum. The old theory of ingestion of contaminated milk or food is no longer accepted. Okay, and more common other reasons are hematogenous spread, especially from active pulmonary or other biliary tuberculosis spot. And the third, of course, is from adjacent organ. One of the common thing is esophageal tuberculosis can be because of the mediastinal lymph node caseation can erode into the esophagus also. So these are all the things. So adjacent organs involving the GIT, hematogenous spread, or swallowed sputum are more common causes. If you know that, well and good. So in abdomen, where all tuberculosis can happen, if you ask me, it can happen in the GIT like Crohn's disease. Crohn's disease in the West, tuberculosis in our country affects from your lip down to the anal margin. It can have anywhere. Okay, it's so common. So it can be in the GI tract, peritoneum, that is ascitic fluid, or in the small bowel mesenteric lymph nodes, or even the liver, spleen, kidney, pancreas, all the solid viscera because of miliary mottling of the all this solid viscera. So it can affect anything. Coming to the GIT, I have seen, if you see this diagram, it can affect the mid-esophageal region mainly, like a mid-esophageal ulcer, mainly because of the lymph nodes in the mediastinum caseating and eroding into the esophagus can give rise to this area. Okay, mid-esophageal ulcer, one of the common presentation. Second, in the stomach, they develop various ulcers, especially in the antrum region, causing rare cause for gastric outlet obstruction or a duodenal ulcer. But by far the commonest site of the tuberculosis affecting the GI tree is mainly this area, ileocecal region, and also the perianal region, like a fistula in anal. If you know that, that is well and good. As you can see, close to 80% of the thing is in this region. Okay, that is the. So, well, let us concentrate only on the gastrointestinal. We forget about the peritoneal mesenteric part for a later description. For a GIT, the common presentation is either they develop like an ulcer, or could be because of the proliferative nature, a hypertrophied obstructive tumor, like a mass. Right iliac fossa mass is because of the hypertrophic or ulcero-hypertrophic tuberculosis. It can happen. Okay, this is pathology. The whole transmural inflammation of the small bowel, if you know that. In other words, each and every word I'm uttering here, it will be something like a Crohn's disease. Because in Crohn's also, it can affect ileocecal region. It is also transmural in region. And it can also cause fistula formation. And only thing is, there in Crohn's disease, that is a non-caseating granuloma. Here in tuberculosis, it is a caseating necrosis. That is the thing. Caseating granuloma is a cardinal feature of tuberculosis. Of course, in tuberculosis, if you're lucky enough, you may be able to grow the offending organisms. Okay, acid fast bacilli. The presentation by far, I told you already, it's a chronic abdominal pain, weight loss, low grade evening rise of temperature, right iliac fossa mass. Okay, so one of the common cause for RIF mass. So acute abdomen appendicitis, chronic abdominal pain. If the patient comes to you, any patient for that matter, sir, I've been having abdominal pain for the last 6 months. One of the differential diagnoses have to be tuberculosis. Second is a Crohn's disease. Okay, it's very, very important in our country. What about the investigation? If you do a blood investigations, patient may be anemic, but more important thing is they have the CESR. Okay, erythrocyte sedimentation rate will be raised. If you do a MAN2 test, very many times it will be positive, but it is non-specific. We should know that it is not a very specific. It will conclusively, because most of you and me, 70% of the people in India will be positive. So it is very, very difficult. But anything above 10 millimeter in diameter, okay, in MAN2 test, take it as a positive. But the positivity of MAN2 doesn't indicate it is a tuberculous abdomen. It is a corroborative evidence. Okay. And also there are occasions where I have seen people with a TB abdomen with a negative MAN2 test also. So this is not a very specific sensitive test. It is, so we don't rely on that anymore, as simple as that. We rely more on the radiological and also endoscopic examination. What is radiological? For you as undergraduate, you should know small bowel enema and also barium enema. There is a large bowel enema. Both can be done. CT abdomen can be considered. And the endoscopy, especially small bowel, it is called enteroscopy. Small bowel enteroscopy. And also cecum, ileocecal region can be seen by a colonoscopy. So there you can go and see the ulcers in the bowel and take a biopsy. So these are the investigations. Rarely you see these calcified lesions in the spleen film, mesenteric lymph node. But what is more important thing is some radiologically, if you are able to see, you'll be able to see the typical picture. This is what they call in exam very often, the mated loops of bowel. The bowel loops are mated together, but very important thing is the deformed cecum, okay, and the ileocecal valve is incompetent. So there is a reflux of the barium from here into the ileum, terminal ileum. The terminal ileum is actually lying in the right iliac fossa, whereas the cecum, because of the fibrosis, is pulled up, becoming a subhepatic, just below the liver. So the cecum, instead of here, the right iliac fossa is in the here. So pulled up cecum. So the ileum is going like this. So in other words, normally you see, for example, this is the terminal ileum, this is cecum, imagine. Now terminal ileum is going up. So the angle between the terminal ileum and cecum is becoming obtuse. It was like this, it becomes like, because, so this is what, so imagine my hand, this is the terminal ileum. So this is the terminal ileum and this is the cecum. So it was like this before, now it becomes this. So obtuse angle. So these are all some classical features of ileocecal tuberculosis. Okay, otherwise called goose neck deformity. That is, you see the thickened cecum, okay, pulled up cecum, and obtuse ileocecal junction. See ileum, cecum. This is the angle. The angle should be like this, but the angle is like this. That's why it is called goose neck deformity. And also the terminal ileum also dilated. The terminal ileum is actually constricted like a string in a case of Crohn's disease. We have seen that string sign of Cantor in Crohn's disease. Whereas here is dilated like a goose neck deformity. So this is a different features. Just to recollect all the 4 cardinal signs and symptoms we have witnessed so far in ulcerative colitis. When you do a barium enema, you see what is called with a loss of ostrations, that is called a lead pipe sign. Okay, in Crohn's disease, the terminal ileum, long, smooth narrowing of terminal ileum, like a thin, watery string of barium, that is called a string sign of Cantor. In hyperplastic tuberculosis, you will see pulled up cecum, distended ileum, goose neck deformity. In tumor in the large intestine, apple course lesion. So all the 4 signs, you just try to see several of these radiological things. All these words have to be memorized and should be vomited during your viva. Okay. Coming to the investigation, further investigations, whenever you see any CT picture, imagine the CT is in front, the cross section of the patient, you are seeing it from the patient's foot end. So when you stand on the foot end of the patient, this is patient the right side, this is patient left side. So this is the right iliac fossa. So right iliac fossa, there is a mass in the right iliac fossa, ileocecal mass. Sometimes lymphadenopathy, sometimes fluid in the abdomen. These are all the 3 classical features in the ileocecal tuberculosis. In colonoscopy, if you see, you can have various features. Now, another CT picture is what we call cocoon abdomen. In other words, like a cocoon, there's a layer of fibrous capsule. Okay. In other words, peritoneal cavity. Inside the peritoneal cavity, if you open, there will be another cavity in which all the bowel loops will be like that. It is a chronic inflammatory fibrositis or fibrosing capsule. So this capsule will appear like a cocoon. So cocoon abdomen, one of the rare causes, TB abdomen. This is the classical CT finding of cocoon abdomen. You can see the fibrous wall here. Okay. And these are all the colonoscopic finding. You can see a stenosis, narrowing of the bowel lumen, multiple ulcerations, hyperplastic tissue, multiple deep ulcerations, circumferential ulceration. Okay, I told you in Crohn's disease, longitudinal ulcerations, snake-like ulcers. Here, circumferential ulcers. There it is a long ulcers. Here it is a circumferential ulcer. So TB, Crohn's. Crohn's is long, like a snake-like ulcer. Serpiginous ulcers. Here it's a circumferential ulcers. So there are some features to tell there are some differences. And this is a caseating granuloma of the epithelioid cells with a central caseating necrosis. And we told you several times, whenever you have a mass in the right iliac fossa region, it is a mass from appendix or cecum anatomically. It could be appendicular mass, CA cecum, Crohn's disease, lymphoma, amoebiasis, actinomycosis. Of course, ileocecal tuberculosis should be one of the important diagnoses. Okay, in addition to all these things. Treatment, tuberculosis, Crohn's disease, unless they have an obstruction, unless they develop complication, usually you give ATT, that is 2 months of intensive ATT 4-drug regime, then 4 to 6 months of 2 drugs regime, that is as in pulmonary tuberculosis, little longer duration, that's all. Surgery is only for people with obstruction, perforation, or bleeding. We do 3 different procedures. If it is just multiple strictures, we do a procedure called strictureplasty. In other words, you incise along the stricture, suture it across the stricture. Incise along, stitch it along, across, across. The 2 words you understand. Then invariably, if you, for example, you just incise along and suture it like this way, then your circumference will be widened. There is a simple way of widening, like a pyloroplasty we do for sometimes for gastric outlet obstruction. Same principle. Strictureplasty, indication Crohn's disease, tuberculosis, or any benign stricture for that matter. But if it is a malignant stricture or very tight stricture, we may have to resect this portion completely and join. That is called a resection anastomosis. Sometimes, if the bowel is so damaged, then you remove the whole right colon, limited right hemicolectomy. What is the difference between a radical right hemi we do for cancer and here in tuberculosis? Here we don't remove all the draining lymph nodes. Okay, it is only we divide the mesentery close to the bowel. So there is no need for, it is only the diseased bowel is removed. There is no mesentery, mesenteric vasculature, lymph nodes are not harvested. It is not, okay, it is not a cancer clearance type of operation. This is a classical hyperplastic ulcero-proliferative growth of tuberculous granulomatous lesion. Few words about tuberculous peritonitis or ascites. Beware of a lady presenting with ascites. When they are presenting, the 3 or 4 common conditions you have to consider. The condition number 1, is it a case of malignant ascites because of ovarian carcinoma? Number 2, is it due to tuberculous ascites? Third, is it a case of cirrhosis, portal hypertension with the transudate, that is ascites? Or is it due to some cause of failure, like a renal failure or cardiac failure, or is it because of hypoproteinemia? These are the rarer causes for ascites. So you know all the causes. So our challenge, especially in a lady, are only 2. Is it because of ascites because of the malignancy or tuberculosis? So this is a typical ascitic form. Occasionally, they can also present with a loculated fluid or encysted fluid. Very rarely, they can present like a cocoon abdomen, like a fibrous form. Okay, that I have already told. These are the people prone for these types of tuberculous ascites. Cirrhotic patients, HIV patients, very, very common. Diabetic patients or patients with the underlying malignancy with the immune compromise or patient with the chronic peritoneal dialysis catheter. They can also get tuberculosis. And they'll have all the classical presentation like pain, evening rise of temperature, and then significant weight loss. But what is important is the abdomen feel little doughy feeling, as if you are just feeling dough, okay, wet powder, okay, so doughy feeling, Or if you feel sometimes you're lucky, you can feel a mass that is usually in the upper abdomen that is called the thickened omental mass, omental cake in CT. Okay, you can see a patient with omental cake, the whole omentum. This is the liver, by the way, a small amount of fluid around the liver. This is the right kidney, left kidney, the renal vessels, aorta, and you can see the pancreas and small bowel loops, and also here all momentum covering the bowel loops. So you should know the whole abdomen is closely studded with bowel. You will not be able to see the seedling, the tubercles in the peritoneal surface can only be appreciated by a laparoscopy. So CT will only tell whether the patient has ascites, whether the patient has a mental cake, third, whether you have any miliary mottling of liver, spleen, pancreas. Okay. And I told you all this Mantoux test is not specific. Very important thing is if the patient has an ascites, you send the ascitic fluid for the following examination. What is the most important thing? You send it for adenosine deaminase, ADA. The adenosine deaminase is a very important investigation we do to prove whether it is tuberculosis. If the value is more than 36 units per liter, it is diagnostic of tuberculous ascites. Second is you look at the patient's serum albumin and look at the ascitic fluid albumin. So serum albumin, ascitic albumin gradient. If the serum albumin is 3, for example, ascitic fluid albumin is only 1, then the difference is 2, isn't it? 3 minus 1. So if anything more than 1.1 is transudate, less than 1.1 is exudate. So if it is tuberculosis, it will be less than 1.1. That 1.1 is a very important statement because in portal hypertension, SAG albumin, we call it SAAG, take it from me, is more than 1.1. Then it is a conclusive evidence of the peritoneal transudate due to portal hypertension by far. Other things rarely can be also cardiac failure, but common things portal hypertension. Whereas if it is malignancy or tuberculosis, it is exudate and it will be less than 1.1. Rarely CA125 also you can measure, but more important is measured in the blood, CA125. This is a tumor marker for ovarian cancer. Then you send the fluid also for the PCR for the tuberculous bacilli. And I told you already, X-ray chest may show some changes of tuberculosis. CT abdomen will show ileocecal mass, ascites. But very important thing is laparoscopy. If you see, you can see the ascitic fluid and miliary mottlings over the uterus, tubes, and all the shiny, small, tiny. So you go and take a small punch biopsy forceps, take the peritoneal tubercles, see under microscope, and look for the granulomatous lesion. That is then put the patient on AGT. So laparoscopy, biopsy, or mini laparotomy. Don't make a big laparotomy because the wound can get tuberculous sinuses. So make a small incision and take the peritoneal fluid and the tissue for biopsy and treat it. These are the differential diagnoses for your tuberculous abdomen. One of the rare things is peritoneal carcinomatosis or pseudomyxoma peritonei. Okay, so that finishes our thing. I think we have plenty of time for a discussion and also 5 quick MCQ. I just stop sharing for a minute now. Let me see whether I can unmute you all. All will unmute themselves. Yes. Can you unmute? Arun, Anuskita, Bharat, Ajit Kumar, any questions? I want each one of you to answer, if not now, in the MCQ. 5 MCQ is going to be posted now. So please volunteer yourself. It's for your own benefit. Okay. If there is no question for the next 2 minutes, I'll quickly go in for the questions and we'll have an easy day today. Any
Sir, good
questions?
afternoon, sir.
Yes, Bharat.
Sir, my doubt is, what do we mean by colicky pain, sir? Does that mean only pain arising from the GI tract or any other pain arising from the abdominal organs like liver and other organs, sir?
Colicky abdominal pain is usually due to some luminal structures. It could be biliary colic, intestinal colic, ureteric colic, uterine colic. Anything is having a lumen trying to push its content. It is a peristalsis, a sign of peristaltic pain. The classical thing is it is usually said, it is usually intermittent in origin. When pain comes in waves, because every time when there is a colic, constricts, relax. Okay, so pain comes and goes. And again it will come. How fast it will come? Some it will take after 5 minutes it will come. Like for example, first stage of labor, it takes some time. Second stage, it comes like that. Same thing, ureteric colic pain, for example, classically it is unilateral. It is, if it is the right ureteric stone, right side, loin to groin pain. Left side, loin to groin pain. So unilateral pain, loin to groin, classical ureteric colic. Biliary colic, right upper quadrant pain, radiating to the inferior angle of the right scapula and shoulder. Classical, the biliary colic. Small bowel colic, central periumbilical pain coming and going. Uterine colic or a ureteric pain, uterus pain or a labor pain is usually suprapubic to start with. But later, because the whole abdomen is uterus, so they feel the whole abdomen is having the pain coming like a waves. Every constriction of the powerful peristaltic muscle gives a crescendo pain, then descending. So pain increases in intensity, decreases, only to come back without warning again and again, repeatedly. And it comes more frequently as it persists. So this is the thing, like a waves. Sometimes waves come slowly, sometimes one wave come after other. Like that. So waxing and waning pain, pain coming in waves, there are various descriptions. One thing patient will say is, patient will be restless. Very, very important. I hope you have understood that. So there are various causes. Any luminal organ can give rise to colic pain. Constant pain is because of the distension of an organ or inflammation of the surface, like capsule, liver distance. So Glissen's capsule distended. So stretching pain. So hepatomegaly can give rise to pain. It will be there day in and day night. It will not go away. Okay, 24 hours a day it will be present unless you give them an adequate painkiller. Perisplenic pain also, like a splenic infarct, can give rise to pain. Myocardial infarction give rise to pain. Pain is there all the time. Constant pain. Here it is a colicky pain, intermittent pain. There is a difference. The colicky pain become a constant pain if the bowel becomes gangrenous. That's the only place where. So a pain which is colicky, which becomes constant, is it a good sign or a bad sign? I ask you a question. Bad sign. That's right. Okay. Any other question?
Thank you, sir.
Yes. Jeannie Jacob. Jeannie Jacob. I think first time we are meeting both of us. I hope you are attending our classes.
Yes, sir.
This is how many modules you have attended so far, Jeannie?
I haven't attended few, sir.
This is the first time?
No, sir, I haven't. I have attended already, sir.
Wait, how many modules? This is module number 14. Out of the 14 modules, how many modules you have attended? Roughly.
6 to 7, sir.
Okay. How did you find? Is it useful, you think?
Yes, sir. Yes.
In what way it is different from your conventional classes you normally have? Which college you are from? May I know?
So I'm from IRT, Perundurai Medical College.
So you are Perundurai Medical College. So you know probably directly about my classes there. So how did you find the understanding of surgery? Easy, or am I telling too much, too little,
No,
or just enough? What's your thing? If I want you to tell either of these three, which one you say? It is enough for you to get through the exam, or it is a bit above the syllabus, sir? Please, this much do I need to know if you have. So I have to pitch it accordingly, because how do you find?
It's enough.
Okay, enough. And you are able to follow all through. There are no lacunae, like in between this part, I'm not able to understand. You have to go and refer. So I have a feeling, whatever we have discussed here with all the pictures, if you are able to understand and if you are able to go and spend some time seeing the same thing again, the YouTube, at least once or twice, there is no need to read this chapter in the book. That's the confidence I have. Okay. So that with that one, you go and write your own story or write in your own template. You will definitely confidently get through the exam. That I can tell you, because it is a time-tested thing. I'm repeatedly telling you, don't joke, because each book will give you a different style. In the exam last minute, you tend to forget a lot of things. So you go by this. Imagine a patient of intestinal obstruction when you write the day when you are asked such questions. Okay, so let's go on to the 5. So I would request all of you, choose yourself one of you, whoever comes first, to choose one question each. There are only 5 I have here as a MCQ. Let me just see. Here is X-ray of a patient with a small bowel obstruction. It is already the diagnosis written on the wall, but still I want somebody to come out with a diagnosis. What is your diagnosis? In a patient, a 70-year-old lady presenting with a small bowel obstruction, X-ray supine abdomen taken, and it shows 3 cardinal radiological features as written here. And if they are present, it is likely to be a case of what? Anybody? Count of 10. 10 seconds I'll give you. Devika, you please try. Yes, who is that?
Sir, Kadiravan from Kurundal Medical College, sir.
Yes, Kaithiravan, go on.
Sir, gallstone, believe, sir. Gallstone is.
Gallstone ileus. Tell me everything you know about gallstone ileus now, Kaithiravan.
Yes, sir. It is due to abnormal connection between the gallbladder and intestine, sir.
Good.
There will be a large connection between gallbladder and intestine, through which the large gallstone enters into the jejunum.
Yes,
And,
good.
it causes obstruction of ileocolic junction, sir.
Yes. So what is the radiologically, what do you see? What do you see in the X-ray? Yeah.
A gallstone at the ileocolic junction,
Yes.
which is mostly radio-opaque, radiolucent, sir. 90% radiolucent, so we can't able to see any opaque structure, and bowel dilatation due to intestinal obstruction, and air in gallbladder due to connection with intestine, sir.
So out of the radiological findings you said, what is the most important thing? 3 findings are mentioned here. Pneumobilia, dilated loops of bowel, and probably a stone obstructing the, or some obstructing mass in the distal small bowel. Out of them, which is very, very important to make a diagnosis of gallstone ileus. If you are asked to, yes, Saranya. Saranya is raising the hand for some reason. Want to answer, or you can unmute, you can tell Saranya. Is pneumobilia. See, pneumobilia is by far the most important thing out of all the things, because very rarely you get a pneumobilia in other conditions. So, cholecystoduodenal fistula, that word has to come because of the communication between the gallbladder, fundus, and the duodenum. The stone from the gallbladder drops into the duodenum. Air from the duodenum gets into the biliary tree. This is the pathology. This is mainly because of the long-standing large gallstone, causes gallstone ileus. Good. Regular triad. This is called a regular triad. Okay. Next, all the following conditions are present. We are prone for strangulation, except what is the odd one out here? Anybody? Ram Prakash.
Sir,
What
good
is
afternoon, sir.
Yes, good afternoon, Ram Prakash. Tell me, which one you think is the wrong answer here? 4 out of the 5 causes strangulation or death body. If you leave it, I'll tell you, I already told you, a
Sir.
band, it can cause strangulation, isn't it? Like that, there are 3 other things cause strangulation. One will not cause strangulation of bowel. 1 point obstruction, because that was a 1 point obstruction.
Gallstone ileus, sir.
Yes, gallstone ileus can cause perforation, but never strangulation. All other things, band, internal hernia, whether hiatus hernia or valvulus or small bowel, intersusception, everything can give rise to. Good, well done. So that is the answer. And here, which are the, out of this, the proximal small bowel obstruction, okay, which is the odd one, which is not the finding in the case of proximal small bowel obstruction. A proximal small bowel means jejunal obstruction, and this is not characteristic. Which one is a odd one out?
Sir, constipation, sir.
Yes, that is who is telling that constipation.
Sir, Mohita Shri, sir, from Erode Medical College.
Good. Do you think constipation C is the answer or D is the answer?
Sir, both.
See, constipation is present whether the obstruction is proximal or distal. See, wherever there is obstruction, nothing is going to come out. So the constipation is a universal finding in all types of obstruction, whether it is proximal, distal, small bowel, large bowel. Whereas the extent of distance of the bowel, abdomen, see the abdomen, when it will get distended, only if the obstruction is distal, then only all the proximal bowel will. If, for example, if you have obstruction at the jejunum, duodenojejunal junction, only the stomach can be distended. So it will not give rise to big distension. So distension of the abdomen is strikingly absent in a case of proximal small bowel obstruction. Okay. Go back to that slide. I showed you a tabular column with the 4 cardinal differences between the proximal, distal, small bowel obstruction. Like radiologically, I told you 1, 2, or 3 fluid levels in a small bowel obstruction, proximal. Distal small bowel obstruction, there will be 6, 7, 8 fluid level obstruction. So more the fluid level, distal the obstruction, because they have a distance of the abdomen. Okay. So that is the response we wanted. Okay. Name the sign. Here there is a sign in a case of small level obstruction. When you do a CT, you concentrate here. Okay. There is something there. Okay. This is a bit too much for you. It is a postgraduate thing, but it will bring you an important, because sometimes you understand the sign and describe. Sometimes you need to write the sign, because the exam they ask you something like this. Okay. This is called a whirlpool sign. Whirlpool sign is, okay, it's like a sulal, you call it. Okay. So because here the superior mesenteric artery, around which the mesentery goes for a twist, there's a classical thing is, whenever you have a narrow mesentery of small bowel in a mid-gut valvulus, in a valvulus neonatorum. The valvulus neonatorum is a disorder in the first few days of a newborn, wherein there is a narrowed small bowel mesentery, where there is a revolve or torsion of the small bowel mesentery like this. And because of that, patient, the child or the neonate goes in for a complete gangrene. Okay. And here the treatment is actually, there is a small band which is going from the cecum across the duodenum onto the abdominal wall. That is called a Ladd's band. Okay. This is one of the rare, the valvulus neonatorum is because of the malnutrition of the gut. Okay. You have to see the development of the mid-gut, the rotation of the gut. So if the bowel failed to rotate, that is called malrotation. This is the penalty they pay. Okay. There is a small band you invariably see as a culprit for developing this entity, that is called a Ladd's band, which stretches from the cecum across the second part of duodenum onto the lateral abdominal wall. That has to be divided, which will help you to unravel and make all the small bowel come to the right half of the abdomen. All the large bowel become the left half of the abdomen in a patient. See, the patient usually comes with this one. You can't make a mal rotated to normal rotation, but at least you can put them all. Okay, all the small bowel, you stay for rest of the child's life on the right side of the body, large bowel on the left side of the body. So be it, like that you say. If they are very close to each other, like here with a Ladd's band, this part goes for the malrotation. So this is the treatment is division of Ladd's band, and then keeping the small bowel on the right, large bowel on the left is an operation of choice for a patient with a malrotated small bowel presenting as valvulus neonatorum. Okay, this is the small, very ultra small or 2-mark question they might ask you. Please understand Ladd's band. Okay, this is, I think, probably the final X-ray. Another newborn from day 1 after birth coming with the bilious vomiting. X-ray taken shows this picture. What is the classical radiological finding? Anybody? Here is one dilated bubble.
Sir,
Another
double
is,
bubble signs. Duodenal
yes,
atresia.
yes, good, Kadiraman, well done. Duodenal atresia, otherwise called a double bubble appearance, because you know the up to here foregut, here it is a midgut. So this is the junction of the foregut and midgut, like a India-Pakistan border. So here, if there is no boundary or the obstruction, atresia, there it will appear like this. So this proximal duodenum, this portion will appear like a dilated, huge dilated gas, and beyond pylorus, and before pylorus another gas. So this is gas-filled stomach, gas-filled part 1 of the duodenal, okay, duodenum part 1. And this will give rise to the typical double bubble appearance. You need to immediately do a duodenostomy. There is a proximal, this portion of the duodenum to this portion, there is a surgery that is called DD, duodenostomy, not gastrojejunostomy. Okay, this is not the operation. You have to join only here. So that is what we do. Okay, so I think that completes. And thank you very much, all of you. Next week we'll go and travel to large intestine, wherein there are at least 4 important short notes like sigmoid volvulus, obstructed bowel tumor, how to manage. I think to some extent we have already discussed. Indissusception, that is actually ileocolic, but we'll discuss in the large bowel obstruction. Then Ogilvie syndrome, one of the rare cause of pseudo obstruction or a functional obstruction. Okay, same time next week. Until that time, thank you all. Have a safe weekend. Bye-bye.